Welcome back to Patient No Longer, the podcast that explores human understanding. I've got an old friend with me. I am so excited to introduce Dr. Brian Silverstein, Chief Population Health Officer at Innovaccer. Brian, thank you for being with us.
Ryan, so excited to be here.
Ryan and Brian, we're going to work the show. So you've got a really rich history in healthcare. You're currently the Chief Population Health Officer. Innovaccer is a leading San Francisco-based healthcare IT company dedicated to accelerating innovation in healthcare. I want to talk about that. You yourself are a national strategic thought leader with expertise in operations and governance. You've worked quite a bit with the Governance Institute, which is part of NRC Health. So you're basically a friend of the family here, Brian. And we're really excited to have you here. Now, you are passionate. If there's one thing I know about you through the years, you are really passionate about population health. You're also the only person I know who has population health in their title. So this is your chance, Brian. I want you to give our listeners and our viewers your take on population health and perhaps what it means for patients.
Absolutely. So population health is a term that was actually coined by David Kindig, who's a researcher at the University of Wisconsin-Madison. But what it in essence really means, it's a philosophy. It's a way of thinking about care differently, where instead of focusing just specifically on an individual patient or focusing on a broader group, it's about how can you understand a group, segment it, and apply interventions so that you can ultimately put the group in a better spot.
That makes perfect sense. And I think it sounds really good. I've also heard something else about population health through, let's say, the last decade, that we've talked about it, but as an industry, healthcare, we've been slow to truly adopt it and to truly realize what it means. What is your feeling, everything you do and know, on the progress of population health, and maybe not just reflecting back, but what the next 5 years hold?
Sure. So fast and slow are relative terms. You know that, and I would agree with you though that if I were to have made a prediction a decade ago, and I did talk about this over a decade ago at the Governance Institute.
I heard you.
I would have thought that we would have more material changes at this point in time. That being said, when you really understand some of the underlying drivers, you can appreciate it's moving at the rate it should. Why? Because it's hard, it requires change management, and a lot of the infrastructure to make it easy. Where's the easy button? The easy buttons don't exist. A vast majority of health systems with EHRs as their core systems, it makes it very difficult to do this. The contracts aren't there. There's a whole host of operational nuances that unfortunately have caused it to move, I would agree with you, slower than I would have expected.
I didn't personally say it was moving slow, but I hear that sometimes. And I was actually asking another guest on this season of Patient No Longer, sometimes in the crowd, you have those people that say, do I really need to change? And, we could pick on board members who've kind of maybe seasoned, maybe a little grizzled in that respect, but I think it's true of executives too. I'm curious, you're great in a room. When you're in there talking about some of these concepts, many more that we'll cover, what do you do when you sense that sort of folded arm? Do I really need to change? Another way I hear it put is, what if we do nothing? What's your answer to that and the perspective that you take if you sense that?
Sure. I think a lot depends on your market, because in some markets, doing nothing actually is going to be just fine. And for example, if you have shortages of physicians, there's not really a lot of competition, if the total costs of care are already very low, then a lot of these efforts wouldn't necessarily create financial returns. I still think there's going to be clinical returns, but there's not funding for it. And as a result of that, doing nothing might actually be okay. It wouldn't materially make a difference. However, if you're in a competitive marketplace, if you're in areas where the total cost of care is high, if you're in areas where employers are active, if you're in areas where there's opportunities, then why wouldn't you want to take advantage of them?
And I think what you say is so true. And I think that describes, I'll say this without data in front of me, a lot of the country. In fact, in our rural areas, I actually see a high sense of urgency where you might say life doesn't change as much. I love rural areas of the country. I was born in a small town, but they're very urgently pursuing new opportunities, new business models to keep care in rural areas. And I think what you say is so true in terms of the clinical. There's another thing that sort of orbits around population health, and I want to put them together and get your take on these. And that is essentially how population reacts or interacts with the social determinants of health. And we've heard really powerful speakers, and you've worked with people who've pioneered the field of social determinants of health. How does that intermix with population health?
SDOH is probably one of the most important factors when you're considering population health. The crux of the issue is when you look at a group of people, trying to identify what's going to happen as a group is actually a science. That's actuarial science. When you take it down to the individual level, that's where it all falls apart. And the reason why it falls apart is because as a group, there's enough volume there that you can accurately predict in total what's going to occur. However, when it comes to the individual, historical healthcare utilization is a minority factor for predicting future utilization. And what really are the majority factors are SDOH.
So say more about that in terms of the predictor, because I think that's really interesting. Can you expand on that?
Sure. So a lot of this is going to depend upon the population and other factors. But for example, if somebody had a pneumonia and they were sick, does that mean that they're going to have a pneumonia again? If somebody ends up having a knee replaced, does that mean they're going to have increased future utilization? There's a whole host. There are some things that it's like, well, if this patient did have a chronic disease like congestive heart failure, they got hospitalized, is it more likely they're going to be hospitalized again? Yes. But what's the difference between all the patients with congestive heart failure? Which ones are more likely to get hospitalized? You might think it's, well, it has to do with disease severity. And that's certainly a factor. But the more common factors are, well, what's happening in that person's home? Who is their caregiver? What happens when a spouse or their caregiver gets sick? Where's the data element for that? What happens when there's increased family pressure to do certain things, or people have dietary issues, or people have transportation issues, they run into financial problems, they can't get their medication. There's so many other things that really turn out to be the causes for unfortunately, the downstream sequelae that aren't necessarily purely, I had this utilization in the past.
And yet so much of our data usage in healthcare, and you know this because you've sat in those rooms, but as we go into 2025, you still don't see a lot of those things on dashboards. You don't see them on reports. You see us resting or relying on traditional metrics. Does that drive you crazy? And in your line of work, knowing what you know, are you able to open people's eyes to all these other factors, a multitude of factors that are really important for what they're watching data-wise, but is not included in their data?
I wouldn't say it drives me crazy as much as I understand it. And the reason why is because if you're trying to do any type of analysis and you don't have the information on everyone, it makes that analysis very difficult. So part of this just becomes a practicality of what data sets exist that we have the data on all the people. Well, it's the claims data. Awesome, let's do that. Then when you start saying, well, can we put clinical in there? Well, for some people we have that, but we don't even have complete clinical sets. Right. It's like, well, how does that get incorporated then? And certainly when you get down to the SDOH, it even adds more complexity. The data actually does exist. And actually with some of the models, you're able to take in Experian data and get it down to the individual level and be able to use that. And while it's not perfect, it certainly, I think, is giving more directionality towards really identifying who are the people that need extra services.
That's interesting how you talk about the data and that it's out there. In our market insights product for NRC Health, we actually started asking direct questions. Now this is self-reported, but trying to cut through the noise and ask people, do you have enough food? Do you feel comfortable making an appointment? Do you have a doctor? Do you have a doctor that you can remember and find? And sometimes you just have to go direct to the source, which is the individual. Now, I want to ask you this question. I've been waiting to ask this one. And I've got it phrased in a very dramatic way. So I'm just going to go for it, Brian. So do you have faith in the American people to take care of their own health? Because we hear a lot about social determinants of health and then personal responsibility versus the responsibility of providers. You know the numbers on diabetes in this country, on obesity, on childhood obesity. We talked to an expert who had studied obesity this season. Where does the responsibility lie? And I guess what I'm ultimately interested in is, can healthcare organizations design programs to help patients if there's still some responsibility on the patient?
I believe that people ultimately want to do the right thing. And in the cases of where patients are non-compliant, or there's always going to be extremes. So there
Sure.
always are going to be some
Course.
patients that are difficult, that are non-compliant, that despite best efforts, but I suggest you a vast majority of patients that are not doing things as prescribed or followed. It's because they didn't understand. It could be because they don't, and not understanding could be I actually physically don't technically understand what you're saying,
Right.
or it could be you've given me a reason and it doesn't make sense to me, so I'm not going to do that.
Yeah.
And I think there's a lot of opportunities with more behavioral approaches to identify what's important to patients. So for example, if you take a patient who's a diabetic patient, unfortunately, and you're talking to them about one of their measures of their hemoglobin A1C, which is a long-term measure of their blood glucose.
Right.
Most patients aren't going to care what that number is because it doesn't have any meaning or significance to them. So when you tell them the number's wrong, it's like what you're doing and essentially is shaming them,
Yeah.
as opposed to explaining, well, here, what is it that it's important to you? It's important that I play with my grandkids. Okay, well, for you to be able to do that, here's what you need to do in order to make that happen. At times we don't translate something into something that patients care about.
And to your earlier point, something they understand, something they can do something with, and make little changes. I mean, it's very well said. And I love how you started the answer that people want to do the right thing. I would agree with you. It's a nice moment there. Kind of heavy too. So this is good timing for the speed round. I bust in every episode, speed round, and every season is a little bit different. So Brian doesn't know these questions. These are completely off the cuff, and the answers are really important. Okay. So let's hit it. Coke or Pepsi?
I'm going to go with Spindrift.
What is that?
It's a carbonated beverage that's made with real fruit, and so I prefer that.
That was a much healthier answer than how I framed it as we were just talking about the nation's struggles. Let's move on. Fiction, fiction or nonfiction?
Nonfiction.
Okay. Morning person or night owl?
I would veer more towards night than morning.
I thought you were going to say both, to be honest, with your
Yeah.
schedule, but either
That is
one
true.
would be fine. Favorite movie or television show of all time?
To go with Star Wars.
Star Wars, great.
Yeah.
Yes, okay. People sometimes hesitate on that. You really didn't. You gave it thought, but okay. And then last one is East Coast or West Coast?
I'm going to go with Mexico.
Okay. All right. We see Mexico.
Correct.
I love that. Okay. I knew you'd have at least one out of the box answer. You had two there. So extra points for you, Dr. Silverstein. Let's go back to something that we hear a lot. And of course, again, you've been a wonderful faculty and advisor for the Governance Institute, very familiar with NRC Health as well as I framed it, a friend of the family. So you and I were both at a Governance Institute conference recently where a CEO in the audience was interacting with a speaker and said, you know, we used to not really appreciate how Medicare paid us, but now we're warming up to it. And I thought that was a fascinating comment, given everything I'd heard a CEO say about Medicare in the last 20 years and how they never pay enough and, you know, other swear words we can't say here. I'm curious, from your very unique perspective, what is your take on Medicare as a payer and maybe just where healthcare leaders are at with reimbursement?
Healthcare is in a really tough spot right now because costs have been increasing, which all of us know. And as a result of that, a lot of the cost is pushed back to the individual. And hospitals make up, depending on which population you're looking at, maybe it's about 30% of the total cost. When you really look at the increases, a lot of the increases are from not the hospital.
Yeah.
And so you're looking at a lot of specialized pharmaceutical products, you're looking at a lot of outpatient services, you're looking at, you know, durable medical equipment, you're looking at a whole host of things. And so the hospitals are sitting there saying, how is this fair? That we're not even getting increases that are at the rate of inflation. And unfortunately, the way that oftentimes systems work is that others are being a little bit more sophisticated about the approaches they're taking. And so hospitals, unfortunately, have not been very compelling. And in addition, because there's so much fixed capital cost associated with hospitals.
Right.
The declines haven't necessarily really been felt yet. And so, we're still in that era right now where I think most hospitals today, they're struggling. The water it's above the mouth, but below the nose. And so you're in that zone of, this is a problem, but we're still going. And unfortunately, until something breaks, that there won't necessarily be a big motivator or driver for change.
And for most people, above the mouth and below the nose is not a large area. And so it depends on how much the water is coming in. I'm curious because your point about being in a tough spot is well said and backed up. What percentage of healthcare leaders in the hospital and health system space truly understand how tough the spot is? Is it a lot of understanding of that and struggle with what to do? Or is the understanding not as widespread as we might think?
I think it's well understood, and I think it's going to be also market specific.
Sure.
Because what's interesting is if you look at national trends don't necessarily always reflect what happens in any given local market. There's so much local market variation that exists that's materially different than whatever the national trend is. And so it really requires, I think that's the opportunity for healthcare leaders, is really to understand their market and know what is it that we should be doing, obviously in considering national trends, but really focusing in on that local market.
The local market part is so well said. And in fact, I was rereading one of my favorite books, which is called Bowling Alone with Robert Putnam. And he has a great line in there. He talks about averages a lot, and then he stops and says, but hardly anyone is average. Because so many people are different depending on their market, depending on where they are. And I think that's really well said. I want to ask you about something that is happening across the country, and it's something we've been talking about for a while as well, and that's disruption, and ultimately the disruptors. You and I have been at many conferences over the years where there's kind of always a new disruptor to parade out there, and they come and go. Right now we've got CVS and Walmart kind of pulling back. Amazon and One Medical are still very much around and very interested in healthcare. Where do you see disruption right now? And also maybe where do you see it in the next 5 years?
Disruption, it's an interesting term. I think that healthcare operates so differently than other industries that you have this consumer, almost it's so foreign how healthcare is. What's interesting though is most people, fortunately, don't use a majority of the healthcare system. This is something that it's amazing how people are able to manage. And so where you see it on the front lines is the simple care. And that's why there's more innovation in that space, because the markets move there, so people are expecting it. When you get to more, where it's unfortunate that you have significant care, right, that's where there's less disruption. What I think is really the big opportunity, though, is what are ways that we actually shift the system. The biggest, if you say, why is the system the way that it is? People are with an insurance company for a year. And as much as we want to say there's a lot of desire to invest in long-term results, that just isn't the case. And as a result of that, there's a lot of unintentional gamesmanship that occurs where it's like, we're going to just do things to get by, as opposed to really that shift. It goes back to your comments about obesity. It goes back to just thinking about health and wellness, what people being compliant or not compliant. In our country, there's so many forces and factors that make it hard for people to actually be proactive about their health. And it is a systemic issue ranging from food, transportation, access to healthcare. All of these things kind of come together. And so until there's a shift in that payment system and the delivery system, then it's going to be just challenging for consumers.
And we've talked about the consumer and the patient perspective, and I love that we were able to dig in on social determinants because I'm very passionate about it, and we don't always get to it depending on the interview. But I also have a doctor in front of me. So I want to ask you a question that I asked a lot of doctors recently on the Patient No Longer podcast. And that's really, again, to paint the portrait of the American doctor. And specifically, what is the future of American doctors, let's say from 2025 to 2030, again, a 5-year view. When you look out that far, do you see a positive future for the American doctor? And if you were trying to recruit doctors in, because I've heard this little thing about physician shortages, how would you inspire a young, bright American or someone abroad to put medical school in their future?
I'm not sure I'd want to inspire someone as much as inform them. I
Sure.
think that the role, fundamentally, the people who are happiest in the medical arts and being physicians are people who they enjoy interacting with people. They're scientists, they're curious, they want to make a difference. What I've observed is that the systems and processes we've put in place have made it very difficult for people to do the things they're passionate about. And we're forcing people to, in fact, do things that are very difficult for them. And so you're taking someone saying, we want you to document this. We want you to look through reams of documentation. It's exhausting.
Yeah.
And I think that you say, what's for the future? I think in the future, there will be better systems. There will be better ways that people are going to be, that will facilitate people taking care of people and people engaging in their health. So I view it as unfortunately, we're in this, nadir right now,
Yeah.
where although we've created all this electronic infrastructure, in other industries, that electronic infrastructure makes it better. Here, it's just made it worse.
It's just there and it's inhibiting and it's in the way.
Yeah.
Very well said, because I think there's a lot of hope that shines through in that answer. And I completely appreciate you not wanting to inspire, but inform. But for my last question, Brian, it is inspiration time. So I ask this of everyone when I close out every podcast interview. You're getting in the elevator with someone else, just you two, and they happen to share with you that it's their first day in healthcare. This is day one. What is a piece of advice that Dr. Brian Silverstein would give that person on that elevator ride?
I would tell them find their passion and joy and make it happen.
Simple, sweet, straightforward, find their passion and joy. I love that. I think that's something that applies to everybody.
Absolutely.
Brian, thank you so much for doing this, for being on the Patient No Longer podcast. It's really great to get your perspective. Just want to thank you again.
Thanks for having me. Really appreciate it.
Absolutely.